Thank you for joining us for the Psycho-Oncology Training Academy bite-sized videos. My name is Dr. Margaret Liang, and I am an assistant professor in the Division of Gynecologic Oncology at University of Alabama at Birmingham. Today, I'll be talking to you about the topic of financial toxicity. I have no disclosures. So at the completion of this module, we hope that participants will be able to 1, define financial toxicity, 2, recognize sources of financial burden on cancer patients, 3, identify the 3 domains of financial toxicity, and 4, apply strategies to address patients' financial needs. So first, I wanted to describe what is financial toxicity. As we all know, patients are routinely counseled on the toxicities or side effects of treatment. This can include anything from rash, low blood counts, neuropathy, nausea, vomiting, hair loss, or fatigue. But now we've come to know that an additional potential side effect of treatment is the costs that are associated with cancer care. And the term that's been coined to describe this is financial toxicity. So as an example, if we had a newly diagnosed patient with breast cancer who is a single mother, she may undergo workup and treatment for her breast cancer, but suddenly be unable to work due to the side effects or the time required to go to her treatments. As a result of this, over time, she may have no money to pay for her bills or to take care of childcare while she's at treatments. In general, we know that financial toxicity can really impact one's overall well-being. So one of the purposes of today's talk is to talk about how to make patients and providers more comfortable discussing the importance of finances, because we know that there are a lot of emotional issues that can surround this sensitive topic. So certainly we know that it's important to develop rapport with the patient. So this may not be the first thing that we'll address in clinical practice, as we know that we have to build trust with the patient and be sensitive to their needs. In addition, we really want to make sure that patients feel safe and assure that they feel that this information is going to be confidential and kept private. In addition, it can be helpful to really normalize talking about costs, so making it a routine part of our clinical care encounters. In addition, it's important to talk to patients about the fact that this may be an ongoing stress during treatment, and we know that this is on top of the stress that they're already feeling with their cancer diagnosis. Finally, if we as providers and care team members are going to talk to patients about their costs of care, we really want to feel prepared that there are some resources available that we can bring up to them so that we don't feel that there's nothing to offer the patients once they disclose their needs to us. Finally, it's really important to make sure that the patient knows that we're on the same team and really humanizing the financial care as part of their comprehensive care. So there are different sources of financial burden on cancer patients that we should all be aware of. So I like to categorize these in 2 ways. So the first is direct costs. So this is anything that has to do with monetary costs. So within this, there can be medical costs, which include premiums, copays, coinsurance, medications, and medical supplies. And there can also be non-medical costs, which are still essential for patients to adhere to their treatment plan. So this can include things like transportation, parking, and lodging. Next, the big category is indirect costs. So I think of this as the time that patients are expected to spend adhering to their care. So this can include loss of work or income, like we described in that patient scenario, the need for other people to participate in childcare needs, and also caregivers who patients often heavily rely on for things like transportation or care when they're feeling poorly due to their treatment side effects. So in the literature, there have been about 3 domains of financial toxicity have been described, and this tries to describe the downstream effects that financial toxicity has on patients. So you can see the 3 here. So there's material conditions, psychological response, and coping behaviors. So we've already talked a little bit about material conditions. So this can include out-of-pocket costs, missed work, reduced or lost income, medical debt, or even bankruptcy in the most severe form. But we also know that this can have really psychological impact on patients. So patients have described feeling distress or anxiety related to the burden of finances that come along with their cancer diagnosis, fear about whether or not they'll get the same treatment if they aren't able to pay for it, isolation, and feeling like a burden to their family. So these are a really important part of financial toxicity also for us to address as a care team. Finally, there can actually also be downstream clinical outcome impact. So this includes patients potentially delaying or missing medical visits due to the cost of care, or not taking their medications as prescribed, so either splitting pills or not filling their refills as instructed. So now we really want to focus on what are strategies for us to address financial toxicity. So here I've put on a high level the different levels where we can intervene to help patients address financial toxicity. So on the patient level, we can make patients feel comfortable discussing issues related to their cost of care. At a provider level, we can screen for financial distress, which I'll talk a little bit about in the next few slides. We can openly discuss cost of care and normalize it as part of routine medical care and cancer care. And we can have the skills to refer patients to available financial assistance services or other individuals who can provide financial assistance to patients. On a health system level, certainly there's room to improve cost transparency for patients and provide financial assistance services, which is also often termed financial navigation. And finally, on a health policy level, restructuring insurance plan cost sharing would certainly decrease the burden of financial costs to patients who are undergoing cancer care. So what can providers do? So the first thing is we can really make financial toxicity a routine part of clinical assessment. So one way to do this is to add distress screening into the routine office workflow. And also, again, feeling comfortable bringing up costs as a routine part of care. So here on the right, I've shown an example of a distress screening tool. This is the National Comprehensive Cancer Network Distress Thermometer. So it's a widely used tool. It actually asks patients to fill out on a scale of 0 to 10 on the thermometer their level of distress on that day that they're being screened. And then beyond that, there's a problem list that shows a list of practical problems, family problems, emotional and physical problems, and spiritual problems that the patients may be having to help prompt a conversation and help us to find resources in order to address these needs that patients are facing. The next thing we can do is to select high-value treatment plans. So in general, we know that if we follow evidence-based pathways, we can decrease overall healthcare costs, which downstream will decrease the out-of-pocket costs that patients experience. So again, trying to avoid unnecessary testing or imaging, as an example, if it's not evidence-based. Finally, some simple things that we can consider is considering if there are cheaper alternatives to the medications that we might be prescribing. So a common issue that we see is that depending on the pharmaceutical tier that a medication is on, if we're able to pick an alternative that might be on a lower tier, it may be cheaper. There also may be generic formulations. Drug discount programs are also available and can be checked for certain drugs, particularly those that have to do with supportive medications like anti-nausea, pain medications, et cetera. And also one other thing we can do to be cognizant about the time patients are spending on their cancer care is to really evaluate the frequency of visits and potentially incorporate telemedicine to decrease their indirect costs. Next, we can really all stay up to date on the point persons and resources that are available at our own health system. So this can include anyone from a social worker, financial counselor, navigator, pharmacist, or financial assistance programs within the community, locally, and/or nationally. So as you can imagine, patients can easily get overwhelmed with all the paperwork and hoops they need to jump through in order to apply for certain financial assistance programs. So it's really important that we have and are aware of what resources and options are available, and to have someone that we've identified on our care team who really knows knows all this information and can provide this information to patients in a compassionate way. So a designated person might be like a financial counselor who knows the right resources and can instill hope in patients, and often take the willingness to walk the extra mile to identify resources for patients in a timely manner. In addition, we can also help patients tap into their social support networks. So another example of this is really to tap into support groups for patients and survivors who may have gone through similar issues. A lot of times patients have described that they find good tips and tricks and advice from other people who have walked in their shoes before. And certainly incorporating caregivers into this process can be really important, as patients themselves can be really overwhelmed, and this support person may actually be able to help them maneuver through and find the needed financial resources easier than the patient who may be overwhelmed. So we hope that you have some tools now that you can use to help patients navigate the financial burden that can go along with a cancer diagnosis and treatment. Here are some references.